watched the film The Lion King or have seen it lately, there's a session in there where Mufasa has been murdered, and Scar goes back to the Lion Pride and tells them all that it was a heavy heart he assumes the throne and announces a new glorious era of cooperation between lions and hyenas. And the end of that story is not particularly good for Scar or the hyenas. Now, this is the same thing, because this is the first time that the section of Oncology and the section of Endourology have decided to work together and have a joint presentation for a whole hour. So we hope it doesn't break up into fisticuffs, and we hope that we can provide you with an entertaining and educative performance from our distinguished panel, all of whom are experts in a nice mix, actually, each of them with some oncology and with some endourology expertise. And my co-chair, Sanjay, is from the section of Oncology, and I am from the section of Endourology, and we've promised not to fight. So, if we could have the first case slides up, please.
All right, thanks. So welcome everyone. As Peter says, this is the first session at joint oncology and endourology, and I can't think of a better subject really, because this is a great example of where the boundaries between these two sections clearly are demonstrated to be blurred. So an MDT meeting, MDT meetings have been around for 15 years, probably longer, and we're all used to them. One of the things about MDT meetings in general is that you have people from different medical specialties, the nurses, etc. We've not got that here today, but I think what we have got is lots of, is that working? Slide. Lots of different urologists, and I think one of the good ways of looking at upper tract TCC is that there's probably no individual urologist that can manage all of upper tract TCC. It's clearly one of these diseases we look after that has many, many different treatment options, and I think the word personalized or tailored treatment couldn't be better suited than to upper tract TCC. So we've got a great panel here. We've got John, Nitin, Peter, and Alistair, and they've all got different skills, as Peter pointed out, and so hopefully when we discuss these cases we'll be able to demonstrate how there are different ways of dealing with them. And upper tract TCC is difficult because it's rare, so most of us will only see a few cases. If you look at the BAUS data for nephroureterectomy, and obviously nephroureterectomy is only one treatment for upper tract TCC, but there are about 1,000 nephroureterectomies done a year, but the median number of cases done per surgeon who does nephroureterectomy is 3. So it's a rare disease, and that means MDTs are seeing it quite rarely too. We know it's difficult to diagnose, difficult to stage. Again, the BAUS data shows that these are older patients, so people having a nephrectomy for RCC are on average about 65, people having a nephroureterectomy are about 70, 71, and a significant number, over 20%, are over 80. The surgery has got morbidity, and the BAUS data for Clavian 3 and above complications is 2.5% for nephrectomy, it's 4.5% for nephroureterectomy, so almost double. And we know these patients don't have many other options when they have symptoms. So it's a really, really good one to get some case discussion on. So we can't really have defined learning objectives because this session will flow. It's relatively unstructured, and where we go with it, we will just have to see. But hopefully it will give some good examples of cases, illustrate the complexity, and hopefully give people an idea of what the different options are. We do want to make it interactive, so there are some microphones. So if at any point anybody wants to ask a question, just stick your hand up or ask for a microphone, and we'll try and get you involved with the discussion. There's also the app to give questions to the iPad, and Peter and I will keep looking at that. So no more delays, let's start. So this case is a case of mine. So a 67-year-old man, a fit, so relatively young man, who's got a history of bladder cancer. So he's 10 years history of high-grade bladder cancer, treated with BCG, which didn't completely get rid of it, but did downgrade it. So his last few recurrences have been grade 2, and we've been managing with surveillance. So first question I'd like to ask, and perhaps Alistair could look at this, what would be your approach to upper tract surveillance in a man like this?
Yeah, so he's had a reasonable initial response, but is still getting trouble. So I'd be wanting to survey the upper tract with a CT urogram, probably an annual basis. Obviously, he's still young enough to benefit from treatment, so you'd have to look at that as he got older, maybe.
Okay. Does everyone have the same view? Any difference views there? What about someone, and it's not maybe not this case, but what about somebody who's got poor renal function? So if his EGFR was 25, what would be your approach there? You couldn't do CT urogram, your radiologist isn't going to let you.
Yeah, so in our centre, usually, and I guess nationally, the cut-off's 40, isn't it? So we would probably be using a CT KUB in those sorts of cases. Obviously, in the more comorbid patients, it's also potentially true that your threshold for intervention might be a bit lower, so you might not worry so much about losing your diagnostic edge a little.
Is there a role for cytology? Does anyone think we should do cytology in these patients? Nitin?
I could use a bit of history. So if his bladder's clear and he's got no hematuria, that helps a bit. And then you can add urine cytology to that because he's got a high-grade TCC, so I'd expect cytology to be positive here. And then I do a CT KUB, once a year or every 2 years. And if I was worried, I'd then do some retrogrades at some point.
Okay, all right. So he was on CT surveillance, and he had a CT in February last year, and it was reported as thickening in the renal pelvis. The radiologist said, well, we're not quite sure what this is. It could be just inflammation. It could be tumour. We did send some cytology, and it was inadequate. John, what are you thinking?
I think this needs visualization, this needs a biopsy, and this is where the overlap between endourology and oncology works well.
Okay. Yeah, I don't think anyone would disagree here, would they? We need to do a ureteroscopy. So that's what happened, and that's where we went. So, we put these cases on because they're interesting and because, things aren't often straightforward. So he went for a ureteroscopy, but the endourologist who did it couldn't get couldn't get a view in the renal pelvis. They sent selective cytology, but it wasn't conclusive, left a stent in, and we're back at the MDT again. So one of the things I wanted to mention maybe at the beginning is these patients keep coming back to MDTs. We know that their pathway is long. So this is MDT number 2. What we're going to do now? Who has it? Peter.
I would say the clock is ticking on this guy. That renal pelvis did not look normal at all, and he's got a previous history of high-grade disease. So I would be very suspicious that he's got nasty disease in his kidney. And if you look at his retroperitoneum, it doesn't look quite right either.
Okay. So
now you've got a stent, so you can't really easily repeat your CT-IVU. So you probably need to go and have yet another look, but you need to make a decision fairly soon. It's 2 months later already.
Yeah. I mean, the urologist who did the ureteroscopy had left a stent in and was very confident that if we gave them another chance, they'd be able to give us an answer. So the outcome of the MDT was to repeat the ureteroscopy in this case, and it was just done a month later. But it still wasn't that easy. They got into the renal pelvis this time, took a biopsy, but the biopsy, as often happens with biopsies in ureteroscopy, is inadequate. I don't know whether maybe, Alistair, you want to comment? Biopsies, taking biopsies at ureteroscopy. Tips, tricks?
Yeah, so using biopsy forceps that will fit down the working channel of a flexiscope obviously limits the size of your biopsy. And the published series have used a variety of different tricks, whether you use a basket to try and snare a bit more volume of disease and take that out whole, or whether you we use the Piranha system, and that produces reasonable size biopsies, but it's not unheard of that they're inadequate for diagnosis. And obviously there are challenges about whether we believe them, other than for a binary decision about whether the disease is proven or not proven. But clearly, the more tissue you take, the better the results. And so if you think you've got adequate access and visualization to use a basket, then that may be a way of getting some more tissue.
Okay. Any other views from the panel?
I'm nervous to give you my view because this is a case from our centre, but it wasn't me. I think the other thing that helps with flexi biopsies is to put an access sheath in, because you'll be going in and out many times, and the more biopsies, really, the better. It reminds me of the story of an old open surgeon that said, why do you put 3 ties on the renal vein? Because there's only room for 3 and you can't fit 4. There's nothing better than more when it comes to biopsies. And the second thing I think that helps is not to withdraw the biopsy forceps through the channel of the flexible scope, because you end up leaving half the sample on the end of the scope, you can get a good piece if you bring the whole scope out. So it's an access sheath. It's as many biopsies as you can take. And if there is bleeding, just randomly hacking away at the renal pelvis to get samples and then putting the stent back in and letting it settle down.
Okay. So we got atypical cytology. So, you know, it's not normal. What do people think we should do next? He's had 2 goes now at ureteroscopy.
So should we just say in the audience,
Yeah.
of the audience, let's have a show of hands, who would proceed this man to a nephroureterectomy now?
Okay, so
Come on. There's 2
Commit.
people got their hands. Be honest, who would do a nephroureterectomy for this guy now? He's got a weird-looking CT. He's got lymph nodes, we think. He's got atypia. Yeah. So there's about 3 of you with what's necessary to be a good surgeon. Have any of you read the book Cutting for Stone? Read the book Cutting for Stone. It tells you what you need to be a good surgeon. Who would not do a nephroureterectomy now? Okay, so at least there's some people still putting up their hands. Good, so most people would not move on. John. Right, what did we do?
what did we do? We did another CT. Okay, so the MDT discussed whether we should go straight to nephroureterectomy, but did another CT. And that's the CT. And it was clearly reported now the thickening had got worse, and the radiologist was worried about the para-aortic area. It looked a bit streaky, and there was a lot of stranding, and although there were no definite nodes more than 10 millimeters, the radiologist was implying this looks like it might be involved. Okay, so what next? Nitin, what do you think?
Suppose now's the time to get on with it and do a nephroureterectomy.
Yeah, but a nephroureterectomy can have many forms, can't it? So maybe elaborate a bit.
I think probably a laparoscopic approach would be good enough and available easily. So using, an incision in the lower abdomen to slide the kidney down, as I think my friend John does, Peter does. He could take the kidney out from the incision below and do the ureter at the same time with a cuff-off bladder.
Okay, does anyone have any different view on how to approach the surgery?
Yeah, so I mean, there would be surgeons who would do this trans, and there would be people who would go retro. So on the left, I think retro is quite a nice way of doing this, and the questions about the extent of any nodal dissection also arise, I guess, from this, and whether you do that purely lap or open. So in my hands, I'd probably do a retroperitoneal lap nephrectomy with an open lower end, but you can often get access quite high to do the nodal dissection when you have removed the specimen. So with a sort of a middle ground approach, really.
So I think you mentioned nodal dissection, so I think that's interesting. What do you mean by a nodal dissection?
So I wouldn't recommend taking a nodal template. I don't think that there's a great deal of evidence that that's particularly helpful, but I would remove all visibly enlarged or abnormal nodal tissue.
Does anyone on the panel think we shouldn't do a nodal dissection?
No, I think you should. I would approach this retroperitoneally laparoscopically, but I would have a very low threshold for converting to open. I think that retroperitoneum looks nasty, and I would give myself 40 minutes or so, and if I'm not making very good progress, I would cut my losses and do it open. I do think you can do a better node clearance open than laparoscopically.
Okay. So again, it's a good one for the audience. Who in the audience would do this laparoscopically? Okay, so quite a lot. Would anyone go straight to open and not bother putting a laparoscope in? A few, small number.
Dare we ask, would anybody use a robot? There we go.
Okay.
And can I ask the panel, who would take the adrenal at the same time?
I think if it came, and it's quite likely to, I guess it'll probably want to come out with this. So yeah, I probably would.
Pete?
Yeah, I would as well, because I want a nice envelope, and I don't want to be skirting right onto that kidney for the sake of saving an adrenal gland. I think you can get a certainly retroperitoneally, you get a very nice envelope of the whole thing, and I think it's technically probably safer and easier in
Good
this
oncology.
particular guy to take
Yeah.
the adrenal. Yeah.
That's it. That's very good. So when I've seen these case presentations before, I've thought, oh God, how do they get them all to sort of to ask the right questions? But obviously, there we go. You just need a good panel because you've asked all the right questions, and we'll see from the pathology. So this patient had an attempt at laparoscopic nephroureterectomy, but it was difficult. The hilum was absolutely fibrotic and solid. Feeling was that this was probably disease. Within an hour or so, it was easy to decide to convert to open, and it came out. But it was, if it was disease that was causing the fibrosis, then it was clear that we weren't going to remove all the disease, and so the distal ureter wasn't taken because it was going to add more time to the procedure. And this is what it showed. So, this guy clearly had incurable disease at the time. What it was in February when he first presented, we don't know. But one of the things about this is, of course, TCC gets worse very, very quickly, and people who treat bladder cancer are very familiar with that. So, I mean, any comments on that from the panel?
Yeah, so obviously there's a lot of different diseases under the umbrella of urothelial cancer, and we've got some evidence from the ureteroscopists that delay in nephroureterectomy to do ureteroscopy or even to treat endoscopically doesn't seem to be associated with poor outcomes, but obviously that isn't G3PT2 disease in the most part that we're treating that way. We're treating low volume, low grade disease. So it's horses for courses, but for these types of disease where we're concerned they've got high volume, high grade disease, you need to get on with it. But oftentimes the patients do have quite a long pathway through, and that's something we all need to keep working on.
Okay, thanks everyone. Before we move on to the next case, any questions or comments from the floor? There's a microphone around if anyone wants to stick their hand up. There's one here. Okay.
Hi, Anthony Timley. Just a comment. Prior to the second ureteroscopy, I'd routinely remove the stent because it allows the urothelium to return to normal, and then you can more easily identify the abnormal area. And I think it's important to put that into the progress of the patient.
Yeah, I think that's a very good point, isn't it? And also, if you're going to do any more imaging, of course, the removing the stent makes that more easy to interpret. Would everyone agree with that?
Yeah, and I think there's also a question about whether you remove a stent routinely before surgery. So oftentimes when we get the pathology at 1 week, we're then on a race to the timeline to get the nephroureterectomy done. I think it probably does make nephroureterectomy, particularly the handling of the ureter, easier if we operate on unstented patients.
I would agree there. Okay, I'll let Peter present.
Srijit Banerjee from...
sorry.
Sorry, I've got a question. After the first failed ureteroscopy, would a PET scan have added anything?
What does the panel think? We can say what we think as the chairs, but that's not our job. Thank you. What do you think?
No, I don't think I would have done a PET scan at that stage.
John, what do you think?
I don't think so. I think it could have been falsely reassuring.
We did too many tests, so not a quick enough operation on this guy.
Yeah.
I wouldn't do a PET scan either.
Okay, well, there's your answer.
I'm not sure about how much evidence there is. It might have shown you the adrenal metastasis, but whether it would have shown you anything significant in the renal pelvis, probably not.
I think the role of a PET is if you have a patient that you think you don't want to operate on because you think you're going to find metastatic disease and it would prevent an operation. I think that's perhaps the role of a PET in these patients.
Yeah, I think there's a lot of problems with verification bias. We just don't have enough information to say whether it's helpful or not.
Yeah. Good, thanks very much. Okay. So let's move on to the next case. Next case, the 81-year-old lady. She was investigated for deteriorating renal function and significantly weight loss. Her renal function had deteriorated during the year 2016, and as part of her investigation, she had an ultrasound scan which showed a right hydronephrosis and a hydroureter. So she's not a particularly sprightly 80-year-old lady. She's got CKD stage 4 with a creatinine of 152 and EGFR of 28, 23 when she presented, 28 a little later. She's had Crohn's disease since 1960 with multiple previous laparotomies. She's got COPD. She had a severe session of pneumonia in December 2016, but recovered fully, although she was pretty much at death's door at one stage during that treatment. She's got a previous history of a pulmonary embolism in 2002, and she's got proven peripheral vascular disease with claudication. Sounds like Eastbourne, doesn't it, Graham? Sounds pretty much like what we deal with. So here's a picture of the CT scan. I can't remember whose case this was. Whose was it?
This is my case.
That's Pete's case, so you're relegated to the backbench for this, I'm afraid,
I'll be quiet.
Pete.
Yeah.
So let's ask John, what do you think?
I think we don't yet know where the level of obstruction is. We don't really know what's causing it. But she doesn't want too many procedures, this lady.
You look at, just have a look on the thing.
Yeah.
We're concerned about that
Okay.
blob in the ureter there.
So the radiologist has
So-
said there's an enhancing
And the
mass.
radiology has said that that is an
Yeah.
enlarged, enhancing mass in the right mid-ureter. Left kidney's fine. No Mets,
Oh, it does
no
say that on
nodes.
there, doesn't it? Yeah. This lady needs one procedure, and I would do a ureteroscopy with a view to proceed to laparoscopic nephroureterectomy. And I'm aware she's had multiple laparotomy, but I would consent her that we have a reasonable likelihood of success with a transperitoneal laparoscopic approach. We put a port in safely, have a look around at the state of adhesions, and proceed with caution.
So that's interesting. So this lady's had, remember, she's had multiple previous laparotomies for Crohn's disease.
Yeah.
Would you still proceed transperitoneally?
I would, yes.
You would, yeah. How many transperitoneal nephrectomies have you done, John?
1100.
1,100. So you've probably got more reason than the rest of us to say that you would do that. How many in the audience would go transperitoneal? Let's have a show of hands. A couple of brave people, good. How many people would go retro? Good. Ali, what would you do?
Yeah, I'd do, I think I wouldn't necessarily do ureteroscopy. I'd probably do cytology first. If the cytology is strongly positive, I'd do a lap-assisted nephroureterectomy. So I'd laparoscope the top end and I'd do an open lower end retro. But I'd be wanting to get this patient to see the POPs team, and I'd be wanting a fairly comprehensive anaesthetic assessment to be done before we took her to theatre. She clearly also is somebody who's got low EGFR, and so there's an argument. It looks actually, it's difficult to tell on one slice, but it also looks like there may be a reasonable amount of renal parenchyma on the right. You can't see the left on this imaging, so it may be of value to have a differential function because rendering this sort of a patient dialysis dependent is not a good outcome.
Good. Okay, so let's see what they actually did. So you're quite right. They did a differential function study which said that that kidney is on 15% or less and that the other kidney is working well. Who else would you discuss this patient's treatment with? You'd get an anaesthetic opinion, you'd sit with the patient. Do you want to bring any of the family in to have a discussion? Any of the members of the panel except Pete?
Yeah, I mean, it's pretty difficult usually to stop them coming in these types of patients, so usually I would expect them to be involved. If they don't bring the family to the consultation, I'm not sure I would particularly make an effort to be forcing that upon them, but you know, usually that would be routine practice, wouldn't it? We'd all usually see these people with their families.
Yeah, it's a good idea to get the family involved as early as possible because they might not think that she's completely compos mentis to decide that she wants to go ahead with surgery. I don't think it's a bad idea. Would anybody want to suggest, Nitin, is there anything else you could discuss with this lady? She's 81-year-old, load of comorbidities. She must be at pretty high risk from what is not minor surgery.
Well, I would be personally concerned about offering a surgery, and I would definitely run it by the family, but also the MDT and my colleagues. And perhaps, I mean, as I work in a DGH, I might even ask for a help from a tertiary center. So that's how I would proceed.
Okay. So she is extremely motivated and she has a very supportive family. They say that she knows what's best for her. Who would insist that she had a ureteroscopy first? How many in the audience would want a ureteroscopy and a biopsy first? Okay. So the point is, this is a lady who's been brought in because she's got pain, she's got right hydronephrosis, she's got an obvious mid-ureteric mass, she is not bleeding, that's not going to be a clot. So what else can it be if it's not a transitional cell carcinoma? And so the role of ureteroscopy is the debate. What does the panel think? John?
I would do the ureteroscopy at the same sitting as the plan will
Just-
throw you. Just to
Right.
eyeball it. We've no
Just
other
to eyeball
evidence.
it.
We've no
The cytology is positive. I think there is a slide that says that. Maybe we missed
Okay,
that. But,
so you
yeah.
can do the cytology, and it is positive for high grade. She's had a flexiscope, it's normal. Sanjay?
But just to be contentious, what did the panel think about doing a ureteroscopy as a trial of anaesthetic in somebody like this and getting your anaesthetist to eyeball this patient?
I think that's just two anaesthetics where one would do. Personally, I would operate on her without ureteroscoping her. If she's got C4, C5 cytology and a negative flexi, I'd just take it out. And I think the time spent, instead of giving her an anaesthetic, would be better spent in POP's clinic.
So that's an interesting point, because I know what my anaesthetist would say to me. She would say to me, Peter, it's not this anaesthetic that kills it, it's your surgery. One small anaesthetic for ureteroscopy as opposed to undergoing a nephroureterectomy, it doesn't tell you anything. The two operations are not comparable. What about the distal ureter? This is an elderly lady with lots of comorbidities. What is her actuarial life expectancy? Do you have to, from your nice retroperitoneal approach, do you actually then have to turn her over and redrape and then make a lower abdominal incision and make sure you get the entire distal ureter out? I guess it's pretty much a yes or no, but we can allow some discussions. Let's ask John, what do you think?
I think so. I think if you don't take the distal ureter out, you're subjecting her to subsequent anaesthetic for stump review. I think you've made the decision to do a curative operation. You do a curative operation and take the distal stump.
Okay. So, anybody want to bring out their robot? Any robotic surgeons in the audience? Why do you think maybe not? Are we worried using a robot because we basically asking ourselves to go trans? If you're going to do a full nephroureterectomy, it's pretty difficult to do that retro, I think. I don't have a lot of experience. Does anybody in the panel have a view about robotics for this?
Yeah, I don't think it would help me, but I'm sure you could do it. The question is whether with a big full system that makes any difference in terms of your risk of puncturing it. Or clearly, if you've not got much space and you go retro, your risk of contamination from fluid is at least not all over the peritoneum. So that's an advantage for retro, but you've obviously got less space, so I suppose arguably your risk of rupture is greater. But I would keep retro and keep lap.
That's a good point that you raise about actually rupturing one of these things, and the whole idea that TCC can seed. If you did rupture it, what would you do? Is there anything you can do?
Yeah, so I probably wouldn't worry about it too much until I was retrieving the specimen, and then at the point of specimen retrieval, I would consider washing out with water. I know there's no great evidence that that's particularly helpful, but it's an old school thing that probably doesn't add a lot of morbidity, or there's no major downside. Yeah. I'm not sure if it's effective.
No, I don't think anybody, there's no evidence anywhere that it's effective, but I think we just feel better if we've rinsed it out with some water. So that is exactly what happened. They did a retroperitoneal, no rupture of the collecting system, lower end was done open. The patient had an uneventful recovery, as they always seem to do. Renal function was unchanged, and she had a T2 grade 3 urothelial carcinoma with all margins clear. She's doing well. Unfortunately, she's still losing weight, so maybe we haven't solved all her problems with that approach. Good.
Okay.
Sanjay, next case for you.
Yeah, we have got 7 cases, but we're conscious we might not get through all of them. So a slightly different scenario now. So this is a very elderly lady, clearly, who presents with visible hematuria. It settles initially, and because of her age, she decides she doesn't want anything doing. Then she has a TIA, and the physicians put her on clopidogrel, and she starts bleeding again. And she's bleeding to the point now where she's getting admitted to hospital. So she has a ureteroscopy, she has a scan, she's got a tumour in her renal pelvis, and a laser ablation is performed. So I think this is your case, isn't it, Alistair?
Yeah.
So maybe Peter, just talk me through a bit about using laser ablation for tumours like this.
It's not something that I personally do, so I probably am not the best person to ask. But I would say at this stage you would want to consider this patient for a nephroureterectomy if she was fit enough and if she wanted that. I don't know if any of the other panel members.
Nitin?
Yeah. I mean, I would be happy to do a laser ablation on her. I would first, before that, consider discussing with her physician if she could change a clopidogrel to something else, like aspirin, and see if it makes a difference. If that doesn't, then yes, I'd be happy to go and do a FIRS and a laser, and probably spend an hour lasering that tumor. And see if it makes a difference. And I've had people in the past who have the occasional episode of hematuria following these procedures, and they carry on for years after that. So it's a chance that is worth taking.
Yeah. John, have you got any comments?
I think clarity over what we're trying to achieve for this woman is important at the outset, and that's a discussion to have with her and the family. Are we palliating symptoms or are we curing her cancer? I think if we're palliating symptoms with a 1-hour ureteroscopy, she might as well have a 1-hour nephrectomy. If we're trying to cure cancer, then we get a CPEX tested and do a nephroureterectomy. But I think it's either symptom control or cancer treatment, and a discussion has to be had around that.
Okay, yeah, now
Yeah, I would agree with that.
Good point.
Yeah.
that's a very good point. I think it was felt in this case that it was just symptom control. This kept her free of bleeding for 3 years, so it was very good. And she's now 97, but comes back in. Okay, and she's now getting admitted to hospital regularly again, transfusion dependent. What do we think? Nitin?
Well, I'm an endourologist, so I will pass it on to my colleagues who do the nephroureterectomies, probably. Or ask her if she wants to have another go at...
She doesn't want surgery. She doesn't want major surgery, she says that.
Well, I would consider stopping her antiplatelet agent, whatever she's using, and see if it's a chance she wants to take. Because if she's had only one TI in the last 4 years or so, and she can stop her antiplatelet agent, it may be a chance worth taking.
Okay, so we do that, she's still bleeding.
Well, then we need to have, again, a clear chat with her about what she wants to do, if she wants to take a risk with her nephro-U or, have one of the FIRS.
I mean, you would need up-to-date imaging if you even want to consider now, surgery, because it's now 4 or 5 years down the line, isn't it? Yeah, and she's 97.
So now the radiologist thinks tumour's progressed significantly. She's probably got nodal disease as well. So we are in a situation where this isn't curable, but she's transfusion dependent and she's getting a lot of symptoms. I don't think anyone would suggest that's laser ablatable. So, we see these patients, don't we? And they're really difficult to manage. So what other options might we have? Any suggestions? Any suggestions from the audience? There you go. There's someone there, Simon.
Why don't you just clip off a ureter?
Okay. Anyone on the panel got any experience of that? Simon?
She'll go home the next day, and you can do it. You either do it lap or you do it under local, open, and it's go home the next day. Great treatment.
Yeah. Okay. Someone's got. You go.
I will discuss embolization of the kidney.
Okay, so that's another option. Anything else? Has anyone else done anything different?
I would consider external beam radiotherapy for the bleeding.
Okay, all right. So those options there for the panel. So
Sanjay?
Yeah, sorry, Tom. Go on.
Embolization in TCC is a complete and utter waste of time. It just will not stop the bleeding.
Okay. Right. Panel, do you want to reply to that? Anyone?
I mean, I think our experience of embolization is that it's certainly much less effective than in renal carcinoma, but I wouldn't, in this situation where you now do not have many options left, I certainly would consider, and I would consider ask about local radiotherapy also to that kidney.
Okay. I mean, that's what they did for this lady. And again, I know it's your case, Alistair, so she stopped bleeding, I believe. Maybe we'll repeat that more.
Sample size of 1, but
yeah.
Well, indeed.
So that was the advice that actually I got from my mentors, was that embolization is probably hopeless, but if she won't accept any other thing and she will accept embolization, it might be better than her expiring from hematuria. We didn't get the suggestion, actually, of clipping the ureter. I don't have any experience as to how well patients tolerate it and what they pain, or, whether there's a common problem with pain and obstruction in patients who've received that treatment. But certainly embolization was completely well tolerated. She has it as a day case patient. She was completely well, went home the next day, and eventually died of something else at about a year.
Okay. Any comments from the audience about that case? Any further comments? Okay. Over to you, Peter.
Okay, fourth case for you to consider. So, male patient, 76 years old, had an ultrasound which was for an assessment of his lower urinary tract symptoms, and as is occasionally the case, they pick up a 7 centimeter mass in the upper pole of his left kidney. So somebody requests a CT scan, and he's referred for review at a central MDT, mentioning briefly that this chap has a history of lung cancer. A radiologist report says the upper pole of the left kidney is replaced by an 8 centimeter infiltrative mass. There's an adjacent small volume lymphadenopathy at the upper pole. There's a picture. What do you think the MDT had to say, Nitin?
I mean, you dropped that thing, lung cancer, in very gently, didn't you? So
yeah.
I think perhaps we should think about that and get some more information on the lung cancer. See what stage it was, see what treatment he had, and see what prognosis he had at that time.
Okay, so he had a right middle and lower lobectomy in 2010, and that turned out to be a T2B N0 PR2 squamous cell carcinoma. He was discharged at 5 years with what they thought was a normal chest X-ray. So he's 6 years later. He's got some hypertension, paroxysmal SVTs, he's got a AAA and some SOBU. There's another picture of his kidney. What do we think?
And that kidney is obviously very abnormal, so we can't really leave it in. That's my first thought. But the lung cancer, again, sort of makes me wonder if we should consider a biopsy.
So the question of the biopsy. Anybody got strong views on that? John?
I should declare an interest with this being my case, so I'll defer giving you my strong views.
Okay, very good. Pete, what do you think?
Yeah, so I think that's a slightly unusual looking kidney, right? It's not an obvious clear cell carcinoma. It could be a TCC, it could be something unusual, it could even be a lymphoma. There's a previous history of another cancer, so I would aim for a biopsy here. You could argue which way you do that. I'd probably do a URS first, I would have thought, being safer than sticking a needle in, I think. But I would go for a biopsy and do some cytology.
So, yeah, so ureteroscopy can sometimes be less helpful sometimes in these sort of infiltrative pictures. You don't always get a diagnosis if you think the patient's got a lymphoma, but obviously we're all skirting around the idea that we're a bit anxious about seeding TCC down a tract. I'm actually not that against the idea of a biopsy. I think the evidence from people who've had PCNL resected tumours probably takes us in the idea that actually seeding might not be as terrible a threat as we think it is. So I percutaneous biopsy, I think.
Okay, they did neither of those things. Clearly, their thinking process was that that's very much an abnormal kidney. And whichever way you deal with it, it doesn't quite look like a TCC, it doesn't quite look like an RCC, but it doesn't look like something pleasant. So they went for the best cover of all options and did a laparoscopic nephroureterectomy. Is this the one that didn't take very long, John?
None of them take very long.
So just before you move on, so we did it laparoscopically, which is fine, but when you're looking at a mass like that, if it's a TCC, it's T3 at least. It could be something else, obviously. What are the views on whether we should do a node dissection in somebody who's relatively young and you're aiming to do a curative procedure? And the other issue is, and again, it's mentioned in guidelines, what about open? Yes, of course, it can be done laparoscopically, but is there a case for doing these open to get a better clearance? I'll just put that to maybe Peter.
So I think the idea of node dissection, we don't know yet what this is, but let's assume it's a TCC, is extrapolated from the pelvic work, where the node dissection is quite an obvious thing to do and not that difficult. The problem here is, what is your template? And to add a RPL&D to a nephroureterectomy is a massive insult to the patient. So it's difficult to argue for that. So I think what most people do is a pragmatic, take out all the enlarged nodes or clear the aorta. But I think it's more prognostic than therapeutic, to be honest, unless you're lucky and there's one little node that you get. But if you're really going to clear the whole retroperitoneum, I'm not sure if anybody is doing that. And you can't do that laparoscopically well anyway, I don't think.
Any comments from the audience about that? I mean, I think it may not be exactly for this case, but I put if it was you, and you had and it was histologically proven as a TCC, and it was stage T3, you've got a choice to make, haven't you? Have it done laparoscopically or have it done open with a template node without evidence. I think it's still an interesting question, isn't it? I don't know what people think about that.
Anybody in the audience?
Would anyone in the audience have their nodes taken out?
Joe.
Just have a small comment. Joe Cresswell from Middlesbrough. One aspect that might come into this is if you had a minimally invasive procedure, got well quickly, gives you an option for some adjuvant treatment, which is really becoming quite a topical thing. The POUT trial, for example, immunotherapy.
No, I think that was our consensus looking at these cases, is that there's not a lot of, in fact, I don't think there's any real evidence to say that a wider lymph node dissection for patients like this offers them any benefit. I think if you've got lots of lymph nodes positive for a tumor like that, you're in serious trouble anyway. And probably in a very small percentage of people, the only thing that's going to save you is chemotherapy, not surgery. I don't think the surgical role for these people is huge, and I think the only thing that's going to help you is chemotherapy. And then I agree with Joe, as quickly as possible, preferably. And there's not a huge amount of evidence for that if this thing is the TCC.
Peter, can I pick up on Joe's point?
Yes, sure, John.
I think your point is really important, which is why he had a nephroureterectomy and not a nephrectomy, because if there's doubt and it's entirely upper tract, you could make a valid point of taking the ureter at wherever you felt like it. But to ensure inclusion in POUT randomization, they have to have a nephroureterectomy. So we, for that reason, would always take the ureter as low as possible to call it a proper nephroureterectomy. The rationale for not performing biopsy in this man was that it was a tumour of unknown origin. The radiologists were certain it wasn't a lymphoma, but whichever other tumour it was the only evidence of disease and it needed out.
Yeah, sure.
That
makes perfect sense. Yeah. So, what did it turn out to be? It's a metastatic squamous cell carcinoma with extranodal spread. The adrenal gland showed no evidence of malignancy. In CT at 3 months showed no intra-abdominal disease, but multiple small pulmonary metastases, which were considered for chemotherapy. Good. So we've got some time left. One more? Yeah.
So this is now, let's go back there. So this is now a case that's a bit more complicated, but it's about, I suppose, what we do sometimes when maybe we didn't do the management we thought we should. So this was a 77-year-old lady. He hematuria, and she had a CT scan. And it's not that easy to see on here, but she has got a tumour in her lower ureter. So radiologists are pretty confident that this is a solid tumour in the lower ureter. You can see it's obstructing the kidney, which isn't working particularly well. She proceeds then to have a ureteroscopy and a biopsy. We've talked a little bit already about maximising biopsy histology, and this was the result. So although the pathologist can say it's a cancer, as is often the case, it was a very small biopsy and they can't give a grade or any idea of depth of invasion. So what do we think, Peter?
So it's in keeping with urothelial cancer, and it looks like urothelial cancer, and that kidney is obstructed, which implies that it's almost certainly invasive. So I would be happy with, and I suspect it looked abnormal when they looked inside there. They might have taken us a photograph. I would go straight to a nephroureterectomy.
Okay. Does anyone disagree with that? Anyone in the audience disagree with that? Okay. This is where life's not always straightforward, because she was treated somewhere else. So this isn't a case for any of our panelists here. And because the histology was TCC, but they couldn't be sure if it was high grade or not, they thought, well, let's do a segmental ureterectomy, which went well, did a Bowari flap. But then, you know, as Peter said, it did look invasive. It was invasive. So clearly, in retrospect, the wrong thing was done. There was CIS at the proximal resection margin. Referred now for a second opinion. So what do the panel think we should do now? Nitin.
Has the GFR got back to a better level?
Well, her renal function, I think, was normal and
Yes.
remains normal, yes.
Right. I'll get the oncologist involved and see how things go. We have two options. Either we wait and see how things go, or she needs to, we need to go in and perhaps, get a nephroureterectomy done on her, because G3PT2 is invasive disease.
Mm-hmm. I also have a question. It looked to me at that first ureteroscopy that they did not pass that tumor. So we don't know whether anybody has looked. So at least if you're not going to go straight and take that, do a completion nephroureterectomy, you need to go and look up that whole collecting system or get somebody to do that for you. Because there might be more than CIS in that kidney. We don't know what's higher up.
Okay, all right. So has anyone got any other views? I mean, would anyone just go ahead and do a nephroureterectomy on the panel?
I think that certainly should be discussed with her. If she had had a primary nephew, she would arguably have been a candidate for the PAUT trial, and probably would have been quite good for that. And so, if she was interested in inclusion in that study, she would need to have that system removed.
Mm-hmm. John, any comment from you?
I think we should, well, the first step will be to restage her to ensure that there is no other extrarenal identifiable disease. But I think she needs a completion nephro-U.
Okay. So that's what was discussed with her. And I think in the end, this patient chose CT and ureteroscopic surveillance. She had bladder disease resected, but her CT was normal. And she's now in a position where she's on surveillance. So what about the surveillance? What surveillance do you think, if we're going to do surveillance, what surveillance do you think we should do? Peter?
I think this is a time bomb right here. I mean, that's T1 as well. It's not even on the bladder. I'd be worried that upper tract is seeding disease. Depending how fit this lady is, I would scan her again, inspect all of her urinary tract, and if she's fit and with no metastatic disease, I think you've got to treat her aggressively and even consider a cystectomy with a nephro-U.
So would you have given her the option of, because clearly I think the patient was given two options and chose the surveillance, would you have given her that option?
I don't know. It depends how you sell it, isn't it? You can, you can give options and you can give options. I would have pushed her quite hard for a nephroureterectomy myself. Yeah. I think this lady will die from her urothelial carcinoma, most likely.
Yeah, I think she's clearly a high-risk case. The question is, if we'd gone and done a nephroureterectomy, whether she would have ended with an interval cystectomy anyway. So I guess that's where the restaging question comes in. But if she's got CIS in her upper urinary tract, and we know that people who present with recurrent bladder cancers are an at-risk population for seeding, you need to be pretty sure that your flexible ureteroscopy regime is pretty tight if you're going to do that. So I guess certainly you'd want to be doing a flexible ureteroscopy within a couple of months of your of the first operation.
Okay, thanks. Again, anything from the audience? Any comments before we move on? Okay, that's great. Yeah. The best picture. You get that one.
Conservative management, that lady is interesting, isn't it? Because we've already said that taking biopsies in the upper tract is quite difficult. So you're putting her on a surveillance plan with not really great ways of making the diagnosis early. Interesting. Case 6. Okay, so he's a 50-year-old smoker with obesity. He's got sleep apnea and he's on 3-agent hypertension. He says to us in outpatients that he's a regular boxer, but he's more Tyson Fury than Anthony Joshua at 20.5 stone. He had a hematuria assessment, and the left renal pelvis shows something slightly abnormal on CT. This is a very difficult patient in himself. He's DNA'd a couple of outpatient appointments. He DNA'd his hematuria investigations. He's very determined in that he does not like hospitals, he does not like doctors, and he really doesn't like urologists. And that is a picture of his CT scan. So who should we bully with this? Whose case was this? Ali's. Oh, okay. Let's go. John, what do you think?
Well, I'm struggling to interpret the CT scan from this chair, so I bow to the report of the radiologists, but I would have a look up and see what I saw.
Yeah. So that's what they saw at ureteroscopy, a 1.1 centimeter papillary tumor. They did get a biopsy and it showed it was a PTA G1. They were difficult to ablate, and as we've said, this chap is hospital phobic and he's a poor attender. So what are our options for him? Let's stick with John.
Thanks. I think this man is unlikely to attend regularly for anything that you do to him in the future. So he needs all guns blazing at the beginning with the best option of curing him for good. And I think we return to a nephroureterectomy, even though it's a small, low-risk tumour in the upper tract. He's not going to come back for upper tract surveillance regularly. Get it out, get the danger over.
I think that must weigh heavily in your considerations for this man. Anybody in the panel got anything else they'd like to consider? I mean, I think was this the case when we were discussing him, Lytton, where you said the much-loved and late lamented Billy Choi said that
yes,
ablating tumours with a laser, what did he say about it?
it's like running your lawnmower over it. You know, you never actually get the roots. You just trim it. We can't really completely clear it. But having said that, a G1 PTA TCC, he's a hospital phobic. I did mention that we should think about maybe counseling him and find out why he's hospital phobic and see if we can get him round, you know, because he might be ill with something else in the future. And I think we need to try and deal with the root of his phobia and see if he can be treated for that so that he can attend in the future. And with a G1 PTA, I would like to try and carry out a left FURS and laser ablation and then checks in the future if we can get his hospital phobia sorted.
I would like to know what it looked like, because you get a tiny biopsy and, you know, if it was a pretty little thing sitting on a stalk, that's different to a slightly more sessile. You said difficult ablation. You didn't think it was going to be an easy ablation. I think that would sway me also, not just the grade 1 T1A.
So it looked like a raspberry.
Yeah, I think we're all, you know, John's view on the fact that he's hospital phobic, he needs one definitive. I think most people would agree with that. But if we take that to one side and just say, look, this is a young patient with a small, what we think is a low-grade tumour on biopsy, and with a lot of comorbidity, that means they may well be in danger of kidney disease in the future. Is that part of your decision? So a 50-year-old with hypertension, obese, small tumour, and we're talking about removing an entire renal system. So again, I mean, yeah, okay, because he's hospital phobic and he might not attend, that's something we should be aware of, but ablation, would that be something otherwise to be reasonable to counsel this patient about and talk to him about the long-term risks of losing a kidney?
Yeah, no, I think that they're clearly key decisions, and if it had been an easy ablation with a good position tumour that was non-sessile, there are features about this tumour, so it's non-sessile and it's just over a centimetre in size that make it difficult. But clearly, losing a renal unit in this man, it's amazing. He is not diabetic when you see him. He is certainly looks like he, has that build that's going to develop metabolic syndrome in the coming years.
Yeah. We've got a question from the iPad, which is great. So someone's asked, does anyone feel a ureteric biopsy ever shows anything more than a TA stage? And so therefore, what's the value of biopsies in staging? Peter, what do you think?
It's a zero. It's to prove that it's cancer or not. Yeah. And if you're lucky, it gives you the grade. But I would ignore the PTA part of the analysis.
Most people would agree.
Okay, so he did actually have a nephroureterectomy, and as you might expect, he self-discharged 30 hours post-operatively. The final pathology showed a PT2 grade 2, which was completely excised. He's refused to go into POUT, and at 12 months, he's recurrence-free. So we're on orange light. I think we're running out of time, and in the interests of handing over, let me say thank you very much to the panel from the Endourology section, and for your input and contribution prior and to today. And Sanjay?
Yeah.
You want to say something from the
the end? There is
can we be the lions and you be the hyenas? And would you like to have the final word then?
How could I follow you, Peter?
Easily.
Yeah, I think thanks very much. I think that was a really good set of cases, so thank you to the panel for providing them.
We can show our appreciation
thanks for the interesting discussion.
Panel, thank you very much.